So good evening to everybody who's already here. Before we officially start, we give it like half a minute, to give time for participants to call in and to enter the webinar room. And I can still see numbers are going up. There are more and more people coming in. And when these numbers stagnate, we start in, let's say, half a minute or something like this. Okay, I think we can start. I'd like to welcome you from my side. My name is Florian Ringel. I'm from the University of Mainz, and also on behalf of my co-moderators Enrico Tessitore from Geneva and Erb Schilon from Cottbus to this EANS spine section webinar, which is a part of our regular series of webinars. We're very happy today to have a special guest, Jean-Yves Fournier from Sion in Switzerland, in Western Switzerland, and who's going to talk about endoscopy. And just to give you some background of our speaker today, he was trained in Switzerland, in Zurich and St. Gallen. He's a neurosurgeon. And then after some more time he spent in St. Gallen, he moved to Sion, to Western Switzerland, to be chairman of a neurosurgical department there. He's very experienced in monoportal spinal endoscopy. He's one of the early adopters of this technique, which is just getting very, very popular now. He already started in 2007 with spinal endoscopy for lumbar disc and lumbar stenosis, and he will share some of his experience with us tonight and give us his views on spinal endoscopy. The title of his presentation is Monoportal Spinal Endoscopy, Extended Indication. So we see where this story could potentially go for, and mastering the learning curve, where we always hear that this is one of the, let's say, crucial points when adopting spinal endoscopy. So I'm happy to have you here tonight to give this presentation. And the setup is for you as participants, as listeners, as usual. If you have questions, please type your questions in the Q&A box, and we'll discuss all those points after the presentation. So stage is yours. Happy for your to listen to your presentation. Thanks for being with us tonight.
So good evening, everybody. Thank you for the invitation. I will share my screen. I hope it's okay. Everybody sees.
Yes, It does work. Perfect.
Good. So my name is Jean-Yves Fournier. I'm head of department at the neurosurgery clinic in Sion. Since probably most of you don't know where it is, I just place it halfway between Zermatt with the Cervin, Matterhorn here, and Verbier. So it's in the southwestern Swiss Alps. And I shall talk about the monoportal applications in the spine. And the second part of my talk is going to be about the learning curve. I will start presenting the interlaminar sacrocyctomy so that we can check the material procedure, and then present the other applications. Just for my career, as Professor Ringel mentioned, I started in Sion, and I spent 21 years in St. Gallen, where I was responsible for vascular skull base and endoscopy, head and spine. I started in 2007 with the monoportal endoscopy. I did a work in the University of Liège with Professor Didier Martin about the application of the endoscope in neurosurgery, focused on learning difficulties. And for some reasons, I came back home, in fact, in 2018. And when I started here in Sion, I had two goals. Of course, to offer the monoportal endoscopy to the patients from my canton, from the mountains here, but also to train endoscopy. And I did a privat docent at the University of Lausanne, focusing this time on the difficulties of learning and some solutions for neuroendoscopy. So we are talking about uniportal, so full endoscopy, and really not about the so-called endoscope assisted, be it biportal or tubular. As you know, we have for the lumbar spine two standard approach, one which is historically older, the lateral or transforaminal, which was developed by Hijikata and later also by Kambin, who described the safe triangle, which bears his name. And then later in 2003, we had another milestone, which is important, the introduction of the posterior approach, full endoscopic interlaminar approach, which allows us to reach all the intracanal pathologies. This is, I would say, the type of procedure I would recommend neurosurgeons to start with because it's the usual anatomical orientation for a neurosurgeon. So regarding the instrumentation, it's fairly simple. The tray is much more simple than for microscopy. We really just need this instrument for a sacrosteectomy. You have a dilator, you have an oblique cannula, the endoscope, of course, and then these are the instruments we need really for a sacrosteectomy. You need the scissors to open the flavum, a rongeur. One is missing. I have also a curved rongeur, a Kerrison, and that's it. Very important is the bipolar flexible probe because it's not only your instrument of coagulation, I would say it's your finger into the patient because it's an instrument with which you have some sensitivity to palpate, and you can use it also as a dissector, as we'll see. Regarding the technical aspect of the endoscope, we use a system which has an oval optic into a round channel, so that even when the irrigation and the working channels are blocked, there is still space for the outflow of water. Another safe element is, of course, the pump, which has been developed especially for the spine application, because as you all know, endoscopy into the spine, it's not the same like into a knee. So we have limited pressure of 50 millimeter HD, and we worked usually with the value of 60 on the screen. So it's 60% of this 50 millimeter HD. The installation is fairly standard. You just need a Caesarean drape to gather the water you are using during the procedure, and you must have the possibility to start with an AP and then do lateral X-rays. So let's go to the interlaminar sacrosteectomy. Patient is in prone position. You make an X-ray. You want to do a small 8 millimeter incision in the center of the window. It's a straight AP, not a true AP. And then you push your dilator down to the window, check it another time. And if you are at the right place, you take the dilator out and replace it with the camera. At that time, you will see some remaining fiber muscles that you will clean with the rongeur and with the bipolar until you have only flavum. At that moment, you also want to palpate here the medial border of the articulation, which is the lateral border of your opening, because you're not going to do a flavectomy. You just make a small incision, which you will start medially, and you go medial to lateral using the cannula to spread a little bit the fibers of the flavum. So it's really a slit. It's not a big opening into the flavum. Once you've done that, you can go forward and go into the canal and identify the neural structures. You will use the bipolar to vaporize the epidural fat. And then you will identify the lateral border of the dural stalk and the beginning of the nerve root. It's monoportal, so you just have one instrument, but you can use, I would say in L5S1 and in very large L45, you can use the oblique cannula as a nerve hook, but you have to be very careful not to squeeze the cauda equina. That's why I precise this is for L5S1 and large L45, but not at other places. This is L5S1, large canal, no problem. We can do this maneuver without squeezing the nerves. It's very important to realize that, because when you're doing the maneuver with the nerve hook in microscopy, you have some feeling of the strength that you exert on the nerve. It's not the case with the cannula. And then once you have only the disc in front of you, you just identify the sequester and do basically the same as you do with the microscope. Then we have the lateral approaches, which can be posterolateral or lateral, depending on the localization of your pathology. If it's more mediolateral into the canal, you will come straight lateral. But if you want to reach only the foramen or the extraforaminal region, you can also go posterolateral. Basically, this is a different technique from the interlaminar, where you have your anatomical orientation. Here, you will need to position the wire and then the cannula under fluoroscopy. Principally, you will aim at the base of the SAP, the safest part of the triangle. We use also methylene blue during this step in order to mark the disc, because the intraoperative orientation is unusual for microscopic neurosurgeons. So we have to train ourselves and to get used to this unusual anatomical orientation. So you aim at the base of the disc, and then here we use the drill to enlarge a little bit the foramen, and then we will identify the posterior longitudinal ligament, which will be also opened. And fortunately, we use this methylene blue, which trick has been given by Beat Welschli from Zollikerberg, who started with transforaminal in 2007. And very practical, because the methylene blue goes the way of the less of resistance. So it goes really very clearly into the disc and not in the other structures. So it helps very much identifying the elements. But still, as it is unusual, before we started this, we went to Fribourg, where we have a possibility to do anatomical dissections. And we opened the back of the patient. We placed the cannula just to get used to see. I wanted to see what will I see when I place the cannula at that spot, just to get used to this unconventional point of view. And for the first cases, we had the chance to have Beat Welschli, who came for our first cases, which is important. As you know, when you start new techniques, some backup is very, very helpful. So this is the complement, I would say, from the interlaminar, where you can reach other pathologies. There are some limitations you have to be aware of. Of course, the iliac crest can be disturbing. The location of the herniation, you can go fairly up, but not higher than the lower border of the upper pedicle. And finally, of course, the stenosis of the foramen can influence your decision. It can be very practical to avoid scar for reoperation cases. And I found in the last 2 years very elegant indications for foraminoplasty patients with a small listhesis L5 S1 and only L5 irritation, with very little work, just drilling a little bit of the tip of the SAP of S1. They were freed of that, and we don't have to think about screws and things like this, because if it's enough, the patients will be happy. I don't have a lot of follow-up, because we just started that 2 years, but I was really positively surprised by the elegance of this procedure. Lumbar stenosis, another of our daily work, of course, because of the increasing need for decompression. And here in Valais, I'm particularly concerned, because it's a little bit the Florida of Switzerland. We have a lot of retired patients, and more than 2/3 are not from the canton, but are retired patients from Lausanne, Bern, and other parts of Switzerland. So it's daily practice. We use for that another type of endoscope, which is a little bit larger. You see, normally for the lumbar disc herniation, it's an 8mm optic. Here it's a 10mm with a little bit larger working channels, which allows us to use different types of drills, as you can see. And basically, there is the possibility to do the posterior decompression with flavectomy and recessotomy on the same side, and then to go contralateral over the top to do basically the same kind of work that you do with the microscope. And when I started these procedures, I was very, I would say, stubborn. I did the all described steps, but after some time with the team, with my younger registrar and colleagues, we tried to reduce the steps in order to be a little bit quicker by this relatively time-consuming procedure. So we do not do all these described steps, which I will show briefly. We just aim at the lower border of the upper lamina, start drilling to find the upper border of the flavum, and then go down the medial border of the descending facet, upper border of the lower lamina, to have the free sides of the flavum completely free. And then if it's a schiza C where we see there is a little bit fat on the midline, we just go up with a punch. And so we can sometimes get a nice square piece of flavum. It's not always the case. So these are the steps which were described to do this procedure. And I say I have done this systematically and cleaned all the structures and identified everything. But after some time, we said we want to try to shorten these steps. And so today we would really do this way, identify as quick as possible the lower border of the upper lamina, drill upper border of flavum, and then free the lateral and lower border of flavum before taking the square of flavum. And then of course, we were concerned about going over the top, but it's not as complicated as we expected. And once it's really freed on your side, go over the dural sac on the other side is less of a problem. You will have much less time for the other side than the preparation on the homolateral side. Here is a video showing a couple of those steps. It's central decompression for a patient with an L3-4 stenosis with a slight lystasis and some bone work to do. Here, the lower border of the upper lamina has already been drilled, and we go down along the medial border of the descending facet. Here, the lower lateral part of the window has already been finned, and we take out the remaining eggshell with the Kerrison punch, trying to free the lower part of the flavum. And then you can use the dissector and the big Kerrison punch to take it out. You can even check the lateral side if you have an herniation. Okay, so this would be next step, in adjacent segment pathology, a large facet cyst. It's also amenable to a endoscopic decompression, where we would do the same kind of work here, the fenestration. And here I just want to show you, see this big cyst over the placement of the endoscope just above the fusion. And then after you've done the flavectomy, you start using your dissector. Really, it's the most sensible instrument with which you can dissect the medial wall of the cyst from the dura. Okay, when starting with stenosis, I would recommend to start with one level simple decompression. And as it will last, plan it maybe at the end of a not completely full day. The ideal case would be one level. The most often are L4-5 stenosis with flavum hypertrophy, maybe a case with not so much arthrotic changes so that you don't have so much work with the drill. L5-S1 is also nice, but it's not so frequent. Some cases we have done with lipomatosis where it's very simple. We had 2 weeks ago patients with a lot of internistic problems and with a high BMI with an epidural abscess L5-S1. And the register was happy to be able to do it with the endoscope and not to have to open, because you all know the kind of difficulties you can have with the wound healing in those patients with BMI, diabetes, and so on. Not so good to start with would be the higher stenosis 2-3 and 3-4, because it's more narrow. You have large articulations, a lot of bony work, or with associated lumbar disc herniation. Or, of course, severe scoliosis, it can be difficult because when we discuss that, we say we go to the lamina, we go to the facet, and so it's easy. But those patients we have to operate with they have a complete change of the normal anatomy, and it can be difficult to orientate in a straight spine. So severe scoliosis can be also disturbing for the orientation. Regarding the instruments, as long as you're outside, do not be afraid to use the Ranger for the preparation, and do not, as I did at the beginning, lose a lot of time with the bipolar because there's no danger. There's no carotid or esophagus, so we can go straight forward and move instead of preparing everything with the bipolar. I use not the diamond burr. I use the normal, the aggressive one, and if I need for the last millimeter a diamond effect. I just push on the reverse pedal, and that's enough. I use the pedal and not the button because on the drill, you have also the possibility to use the fingers. But of course, if you're drilling, something happens and you have to look for the button, you lose 1 or 2 seconds. That's more safe, I think, to work with the pedal. Why should we spend so much time trying to be less invasive? I think it's fairly clear from the history. I started here 30 years ago, and I learned without microscope with the very large Luer, which we called La Grosse Bertha. And we would take away the spinous process, we would take away the laminae and large part of the articulations. So that leads to 25% postoperative instability, and meta-analyses have shown that when we introduced the microscope and kept the midline structure in place, it drops down to 18%. And very quickly, at least in St. Gallen, we adopted fairly quickly unilateral window and crossover, and there it goes down to 12%. I don't know if there are already numbers about endoscopy, but probably we are even less invasive than the unilateral window. We don't touch the muscles practically at all. So probably it will even drop more. And this is absolute in the philosophy of our department. And it's also the philosophy from Professor Kim Luke from Seoul, who is doing this for practically 20 years, that we want to save the structures as much as possible in order not to produce these postoperative instability, because we all know the stories of the next Tengman fusion. You start at L4-5 and then L3-4 and so on and so forth. So if we can postpone the moment where we should maybe do the fusion, I think for the patients, that's a good thing. Of course, we can expand also the indications for endoscopic assisted intersomatic fusion. It's endoscopic assisted because, of course, we cannot put the cage through the working channel of the endoscope, but here it's possible, and you will do a discectomy under direct vision. So believe me, this is going to be a clean discectomy. You will see every piece of disc resting there. The disadvantage of the technique is, of course, that the cages we can expand through the 10 millimeter cannula are not so large like an X-leaf, and at the moment we cannot correct so much the lordosis. So, but we hope that there is improvement. We already tried a new cage which is larger than the first one we had, and we're waiting for models with more lordosis. Another very nice indication is, of course, spondylodicitis. We presented here at the Spinal Swiss Society in Geneva 2 years ago this case of spondylodicitis in an 83-year-old patient who was in bad condition. He had 6 weeks antibiotic on the internistic ward, no diagnosis in spite of 2 CT-guided punctures, and finally they called us, and he was not in the shape to do big procedures, but 40 minutes with the endoscope, rinsing, securing the diagnosis, because you take all the disc away and then you have a much higher chance of getting the bacteria than with a simple CT puncture. And you will do the treatment because you will be rinsing with 15 liters, and so the bacteria will be out. So this is very elegant, minimal invasive procedure. Next step would be Frickholm, which was introduced in 51. He did his dissertation under Oliver Kroner. At that time in the French part of Switzerland, we would speak rather from Scoville 30 years ago, rather than Frickholm. And it was the standard until the cages came, and then we went to ACDF as a standard. I have to say, when you have a patient with a radicular pain due to one disc herniation or one foraminal stenosis, if you do tubular Frickholm, then you will do fairly the same with the endoscope, looking for this triangle-shaped window and drilling the window open so that you can reach the nerve and the disc. Here, the case of a rugby player with a calcified disc herniation C7T1 with a C8 radiculopathy, non-neck pain. So we go down, identify the cranial caudal lamina, the facet. And once we have identified those structures and cleaned it, ready for the drill, we can open the window. And we had a very interesting discussion a couple of weeks ago in Sofia, where the cervical decompression was also presented as a good procedure to start with, because you do the same. Really, it's nothing different. The only thing is you have to be well trained with the drill, just not to have accidents with that. So I would recommend maybe to start as soon as you have a good control of your drill in lumbar decompression. So if we make the summary of the pro and the cons, with endoscopy, you really have all the advantages of the posterior approach, because you do not have sensible structures like from the front, no recurrent nerve, carotid, or whatever. The patient keeps his disc. You don't have to break your head asking yourself, do I put a cage or a prothesis or a cage with or without plate and screws? And you have not the two disadvantages from the posterior approach, which are the pain of the muscular incision and the infection, which is a little bit more frequent in posterior approach than in anterior approaches. So when we summarize, we have all those possible indications. And if I would recommend a kind of progressive introduction of the endoscopy, I would recommend to start with simple cases for interlaminar sacrocyctomy. And what is a simple case? A simple case is a young patient with a disc herniation which is not migrated or migrated cranially, because those are not so much more complicated. No arthrotic changes, so no need for a big fenestration. And then you can go to less young with some use of the drill to enlarge the window laterally, and then caudal migrated, and then recessal. And then you can just add one more difficulty, one more new element, which would be transforaminal with the change of the point of view. And as soon as you have that, you can go to thoracic disc herniation. I didn't show the video, but we've done a couple of cases. It's extremely elegant as compared to a costotransversectomy. Or you go to the stenosis and get used with the drill. And as soon as you have the drill under control, then you can go to cervical posterior without any difficulty. BMI, by the way, is not a complication. On the contrary, I think patients with a high BMI will have collateral gain from an endoscopic approach. Regarding the complications, nerve lesions, it's not complication management here because we can't do so much. It's complication avoiding. So here I would recommend not to do any turning maneuver with a cannula in a canal which is narrower than 15 millimeters. Regarding dural tears, there we have here complication management. The advantage is if you have a small hole, and this you can easily evaluate the size of the hole with one of the instruments. If it's less than 5 millimeter and you do a disc herniation, you don't have to do anything. Nothing will happen. If you have done a flavotomy, everything will close and there will be no leak. I will show it in more detail, the possibilities. And regarding bleeding, you have different possibilities: irrigation, bipolar, bone wax, flow seal, or conversion. I must admit, conversion, I cannot remember of a case in the last years where I converted because I didn't see anything because of bleeding. So in some way, you must have with this possibility, the possibility to check that. One of the frequent reasons for having blood in front of your endoscope is that the irrigation doesn't work because, we have these saline bags, and if the personnel in the theater is not attentive and not regarding, then you don't have water and you think it's starting to bleed, but no, it's not the problem. There is no water. So the personnel has to be very precise with the change of water. Moreover, if they do it with delay, you might have bubbles and so on, you have to wait and so on. So that's a training of the personnel needed. And finally, sometimes if you work and turn the instrument, you may have the disconnection here and you're struggling to coagulate, but you don't have rinsing anymore. So very first point to see. Otherwise, for bleeding, the recipes are clear. Get close to the source. Very often, your vision is simply blurred because you have tiny capillaries, even from the flavum, which can disturb you, and you will control that without difficulties with the bipolar. When you're drilling, you can drill with the diamond or reverse normal drill, which can close some of the hole from the bone. And another possibility is during this phase of drilling, you can increase the irrigation. You can also use bone wax. Here, I would not recommend to go with bone wax on the dissector through the working channel because half will remain on the channel and then you will have difficulties passing the instrument. So I will show that how to do. And finally, flow seal. There are special applicators for the endoscopes if you really have difficulties. That would be the application of the bone wax. Here, you see the endoscope is out of the cannula. The assistant must hold the cannula in place. Then you put the instrument through the working channel. You place your piece of bone wax on the dissector, and then you can go again through the cannula and apply it. Another possibility is to place the bone wax on the head of your drill, where it holds even better than on the dissector. So finally, I would recommend to check the hemostasis at the end of the procedure, because if you have the irrigation, you will always have the impression, oh, that's good, but there might be some remaining bleeding sources. So at the end, I just stop the irrigation, check if there is any relevant source which I should coagulate, because an epidural, not in a stenosis where you have done a decompression, then it's an hematoma and there is room to expand it. But if you have, of course, a flavotomy and it closes when you go out with your endoscope and cannula, that can be very dangerous. Finally, for the dural tear, as I said, small lesions, you don't have to do anything. You can place a tachosyl patch with a ronger. If it's larger, just check, are the rootlets exciting? Check for the arachnoid. Sometimes it's difficult to see, but sometimes the arachnoid is still intact, and so you don't need to convert. But if, of course, if the rootlets are out, you don't get them inside, and you cannot place a reasonable piece of tachosyl over it, then you will have to convert. Most of the time, we don't have. I've heard in Essen in April that there are new instruments to do the suture with the monoportal. Biportal, it's already possible, but monoportal is coming, doing the knot outside of the optic and having a knot pusher to do the knot. But most of the lesions are quite small. This is a recent case of us for a lumbar disc herniation cranially migrated with a small hole. And you see this is a 4 millimeter drill, so it's a 3 millimeter perforation. We're not even sure if the arachnoid is perforated, but we just go on with the procedure. One element is to reduce the irrigation. We put it on 40%, just not to push the water inside, and go forward to complete the procedure. Find the lateral border of the sac, and then take this upwards migrated L4-5. And at the end, we placed a small piece of tachosyl here through the working channel, and it worked fairly well. It was Monday, patient is going very well, and he's going home tomorrow. So then we're here. We have a very attractive procedure, less pain, less postoperative instability, scar, zero infection, operation time. We are quicker with all the lumbar disc procedures, but not so with the stenosis. And still, we are fighting with the learning curve. And we have a lot of studies which show in all items the superiority of the endoscopic procedures. So we would like to offer that. There are even other advantages than the standard measure. For revision, we have less scar, less complications. For obesity, less dissection, less complication. The infection rate is practically zero. I touch wood. I had no infection since 2007 of these classical wound infection that we see in open microscopic surgery. Anesthesia techniques, there's more flexibility. There are several colleagues who do that transforaminal. they present less neurological complications because as soon as you are with an instrument in the vicinity of the nerve, the patient will react. Ambulatory center compatibility, this is also becoming very attractive with our difficulties with operative slots and beds in hospital. Regarding limitations, we have not so many limitations. Anatomically, at the moment, we stop at 2 levels because at 3 levels, we're still too slow to offer that. We have done a couple of cases with a very favorable low doses where with 1 incision, we could decompress the 3, but still, it's not so quick. And finally, the foraminal height with change of diameter, change of location of the inferior border nerve in relation to this disc space. This is also a problem that might break the diffusion of the technique. Other limitations are, of course, expenditure reimbursement, the surgical cost. It can take care to show the benefits to the hospital. Here, I could convince the financial guy because I showed the number of complications which we do not have anymore. They are very expensive if you look at the figures of how much does it cost. And also with the mean hospitalization time, we also save enough money that I could convince the direction to introduce that. But still, we are here 30 years after the introduction of gallbladder endoscopy, where it took, as Claudio Tome mentioned, it took 3 years to the general surgeons to change and to adopt the technique. And we would like to offer this very elegant technique, but we cannot because the learning curve is flat. It's not a steep learning curve. A steep learning curve is a good thing. It's not mountain climbing. When it's steep, it's easy, 5Ks and you're an expert. But it's not the case at all for endoscopy. And we have to fight against this long learning curve because this is a period where the patients are exposed to complication. So I looked through the literature. There is some inhomogeneity. If you look for monoportal or full endoscopy, you don't find anything. And for the rest, it's all mixed. So you have to sort out all this literature. I just present here my series from the very beginning in St. Gallen, where I had a learning curve for very simple selected L5S1 cases, more than 30 cases. And that was what was published. We say 15 to 80 cases. This is the most recent, October 24, where they studied 13 publications, more than 800 patients, amongst them the 76 from St. Gallen. First procedure, 90 minutes. I also had more than 100 minutes, I think, the very first case, because we were struggling with the identification of the flavum at that time. And you see 20 cases to overcome the greatest part of the learning curve. So clearly introducing spinal endoscopy, it's not like kyphoplasty, where we went to Leiden or to Innsbruck and or Salzburg and had 1 course, did a couple of procedures, came back and started. This doesn't work. And we know that Switzerland is a small country. We have more than 20 very experienced surgeons who have done cadaver courses, but none of them have done more than 3 trials before giving up. So clearly, this is not enough. We have to do more. I had already worked on the difficulties in the endoscopy for the pituitary surgery at that time in Liège, and we had identified all the differences between micro and endo work. It's not 3D, it's 2D, it's in direct vision, the anatomic structures under the irrigation and the light, which is a couple of millimeters. It's different. You have small instrument. The movement freedom is not the same. The tactic is different in microscopy. The target is always in the center. In endoscopy, not so. And so this will completely block your working memory. Even if you're very experienced in microscopy, you cannot just see one, do one, and then do the same, because it's clearly not the same. Moreover, there are other challenges. The left hand has to be trained. In microscopy, it's the right hand that brings the drill to the target. Not in endoscopy. In monoportal endoscopy, you will have to train the left hand, which have to bring the endoscope to the target. So there are a lot of things to learn. Planification for extraforaminal, you have to get used to new elements that you don't use in microscopy. So clearly, there is a lot of work to be done. For pituitary surgery, we had developed a basic cheap model, 3D printed, where we placed a boiled egg at the base of the cellar floor, and the trainees had to they have to take all the yellow egg without disturbing the egg white, the posterior egg white. And this is an exercise that we do for the skull base course in Liège. Before the trainees who have never held an endoscope go to the cadaver, they do the egg, and then they know how to hold the instrument, how to hold the endoscope, because it's a waste to do it on the cadaver, we think. And when I came to Sion, as I said, I wanted not only to introduce the endoscopy, but also to train the endoscopy here in order to reduce the learning curve. I had the chance to be connected with Michael Piccirillo, who is an educationist from the NAS, and he helped me to for the conception of these training courses, which we made. We started the first one in September 2018. We showed for the feasibility to do endoscopic training with realistic models. Then we made improvement suggestions, but the models were not so cheap. And we have done in the last 5 years, you see several courses with 4 to 6 participants with these practical exercises where the participants did 4 times the procedures and assisted alternatively 4 times. So at the end of the day, they have participated to 8 surgeries on realistic models. And several of them were friends, and they told me that they learned really good things during this course, very practical things, but they were not so cheap. And I was looking for the egg for the spine. And so we found finally the king oyster, which is a mushroom which has a very interesting consistency. It's nearly the same than the yellow ligament. And combining the half foot of a king oyster with a finger glove filled with water over a sponge, we can train basics movement, basic procedures like the sacrosectomy, where you learn how to open the flavum and how to mobilize the dural sac with the instrument. And you can also learn the tactics, of course, even basic things like endoscope holding. If you don't learn how to hold the endoscope without getting tired, after 20 minutes, you cannot continue. So these are basic things that have to be trained outside. And then we have the possibility on a small simulator to train the steps so that some automatism gets in, that the next step is already integrated in your brain. And we started with a simulator which was with low haptic feedback and some colors, but not so fairly. But it's informatics, so it gets improved every year. And now we're getting something very realistic where the youngster can train the placement of the endoscope with a simulation of the X-ray. They can train the use of the bipolar. They can train the use of the Ranger and do the sacrosectomy. The time issue are important for all the procedures with disc herniations. We are quicker. When I say we, it's not me, it's the team, the youngest team. They are quicker than in the microscopy. As I said, it's not yet so for the stenosis. Here, the learning curve environment, which changed when I think of my situation in 2007, when I had a couple of very selected cases every month with no backup, no training options as compared to today. And my assistants, they have daily assistance possibility. They have a 100% backup, and they have this cheap model simulator cadaver where we have the possibility to go every 2 months to Fribourg. The material has also improved. I started with a working channel of 2.8 millimeter. We have 4.8. It looks not so important. It's very important because the Kerrison punch 2.8 millimeter, you cannot remove significant pieces of bone. You can remove some pieces of yellow ligament, but not really bone. And the irrigation is safer, it's controlled. So a lot of modification in the environment. And we have a concept where our trainees have regular exposition. They can train the basic skills on the mushroom model. They can have the automatization on the simulation, can do the procedure on 3D realist or on the anatomy. And the first cases are with backup. Moreover, as often as possible, I engage the registrar or the advanced assistant in training courses. As you know, this is very good for fixation of the knowledge, much more efficient than frontal instruction. And with this recipe, when I observed these 17 years, I had, as a beginner alone, more than 30 cases, as it's published. My register had 15 cases. He had backup, so that's part of the solution. And when you use all the options that we have here, we have registered young colleagues since 2020 that are able to master. Even on weekends, when I'm not here, they no one of them had more than 10 cases before being independent. So take home message, case selection with progressive difficulties when you want to start. The learning curve is not steep, time will be needed. Know how to manage the complications, the two ones that we mentioned, bleeding and dural tear, and avoid nerve lesions. Be stubborn and don't abandon as soon as you have conversion. I did a drama when I had to convert at the beginning, but in fact, if you don't lose 2 hours, just give you time limits, the patient received the standard procedure or still evaluated as standard. And also develop training options, because you will start maybe with interlaminar, and then you will go the next, and maybe you want to train again different things before making the next step. So that's it for me.
Okay, great. Thank you, John. It's very, very nice presentation, very, very comprehensive. And I like your training concept, and it's impressive how you could show that you can essentially bring down the numbers by your concept to what you last said about 10 cases, and get people sufficiently skilled to do this endoscopy when nobody else is in the house. So are there any questions? I'm looking, whenever you have questions as a participant, please type your questions in the Q&A box, and we're going to read those questions. So far, there's no question coming up. I have a question regarding your lumbar stenosis treatment. If you go, you probably go unilateral and do over the top decompression of the
Exactly. Yes.
contralateral side. So where's your entry point? So is it a bit paramedian to get sufficient angulation? And if you're paramedian, how good can you decompress the unilateral lateral recess? So what is how much degree of freedom do you get to the ipsilateral lateral recess and get to the contralateral lateral recess with one approach in an, let's say, obese patient or a bit adipose patient?
Very good question. In fact, we tend to aim at the junction between the lamina and the beginning of the spinous process. So we are quite medial, and then we also drill a little bit of the basis of the spinous process so that we can do both. And as I said, when you have then the homolateral decompression, I was really surprised. I was worried, how do I get on the other side? And so, but there is enough room, and the irrigation will push down the dural sac nearly flat. So you have quite a lot of space, and you can go without great difficulty to the other side to take away the flavum with the Kerrison punch. But really, we do aim at the lower border of the lamina at the junction between spinous process and lamina.
Okay, good. So when we see those videos from spinal endoscopy, we always see that it starts on bone. Usually the videos start on bone. But how do you handle muscles prep before you get contact to bone? Because the bone in the videos is always clean from muscles. So I mean, you can't do it as usually that you push the muscle away. So it means you go down with a cannula, and the remaining part of muscles are coagulated and cut out, or how do you?
Exactly. Normally, there shouldn't be a lot. If you do really, you go to the contact with the dilator and with the cannula, check on the lateral X-ray that you are really down at the level of the articulation. There is not a lot of muscles. I used to coagulate a lot. And we had this discussion 1 week ago in Lucerne at the first user meeting for monoportal endoscopy. And there are two types of surgeon, it seems. There are the ones who want to be very safe and to see no blood, and they burn everything. And it's really, that's a little bit time consuming, but then you have clean structures, or the ones who want to go quick. And I am moving to quicker, because I also spend a lot of time to make clean anatomical preparation, but I don't think it's really useful. The only moment where I use the cannula as a raspatorium is maybe over the articulation sometimes to get the soft tissue away from the articulation. But the rest I would do with the ronger or even with the scissors. I would cut the muscles insertion at the border of the lamina, the fibers there.
Okay. Ehab, you have a question?
Yes, thank you so much. Really nice talk. I enjoyed it a lot. My question is, do you sometimes need to add some adrenaline or some kind of medication to the infusion for the solutions that you have less bleeding?
I don't do that. I was not aware of that possibility, but we discussed that last week in Lucerne, and the colleague in Baden, they did that sometimes in order to reduce the bleeding. I have no experience at all with that. And as I said, I didn't have to convert in the last years because of bleeding. Most of the time, I would say it's not dangerous. It's just getting you nervous because you don't come forward. What I don't do anymore is just waiting and rinsing. I try to be active. And if it's bleeding on one part, sometimes I just go on the other part and work. And when I come back, it has stopped. The most disturbing thing where I get my nerves really screwed is the drilling on the bone, because there it's sometimes difficult. And I try to go forward. And as soon as you are down on the cortical part, the lower cortical part, it stops. So probably that's also a recipe in order not to lose too much time, because time is really an issue in stenosis procedures. And we are trying here, fighting to improve, to optimize our work. One is the reduction of the steps I mentioned. And another one is that not losing too much time on bony bleeding, trying to go forward. One possibility is also to put the bone wax on the head of your drill, which will also help stopping these bleeding holes. But the bipolar works also. If you have a good angle, you can exert some pressure. It will also close bony bleeding.
Thank you.
Now we have some questions from the chat. The first one is, how do you inject the methylene blue exactly? Maybe you can comment on this further on, and in which cases you use it.
Yeah, we used it at the very beginning for the extraforaminal approach, and we inject at the beginning. We do this orientation with the needle, the first to place, and when you have the needle in place, you can inject at that moment. You have to dilute the capsule of methylene blue. The first cases that was done, we did not dilute enough, and the patient had blue urine after, and we all get nervous, but it's not toxic at all, so there's no issue for that. But this is at the very beginning. Before you place your dilator, you have to place the wire, and the wire goes through the needle, and you need to use that moment to inject into the disc the methylene blue. It's really interesting to see where it goes the way of the less resistance, and it's going to be the disc. Okay.
Now we had a question regarding the difference for biportal versus monoportal endoscopy. So I mean, this is an important question when you pick up this technique. Should you go biportal? Should you go monoportal? What are the differences? What are the advantages of biportal and monoportal? And what would you advise to go for?
Well, I'm quite convinced that the monoportal is clearly the less invasive. And I think as a neurosurgeon, that's what I want to offer the patients, the least invasive. I have tried both. I have also had biportal instruments it was 2 years ago. I always hear that it's easier to learn. Yes, but there are some issues which are not so simple to resolve. I think I found it, for example, going as a right-hander, when I go left, where do I put the camera and the instrument and so on? There's some issue where you have to solve. And then if you look at the images of the preparation, for example, for cervical, or if somebody is doing elegant microscopic tubular surgery at the end, the tube is only a little bit larger than the stenosis cannula, and you just have a couple of fibers to take away down. So for biportal, you have to create the cavity to see your instrument. So from a muscular point of view, it's more aggressive, I think. So for me, offering the best technique, it's full endoscopy. But we will not close the door to biportal. The only thing is I came here from a large clinic to a small one, and I introduced monoportal, and I said it's not good to divide the number of patients we have between the two techniques. But we shall also build up biportal endoscopy. I have a register who is now 2 years in Geneva in the orthopedics clinic where he did biportal. He's going to bring that technique. And I think we shall apply it in cases where monoportal reaches its limits. There is a presentation from Kim Luke also where he shows the surface covered by monoportal and the surface of biportal, which is a little bit larger. And we will use the biportal for those indications, but for the rest, we will offer the monoportal. And I think this technique might be a little bit more difficult to learn, but once you master this as neurosurgeon, it's not going to be difficult probably to learn the supplementary tricks for biportal. As orthopedic surgeon, of course, it's different because they have a lot of training with biportal. They do the whole knee and endoscopy, so they don't have to learn anything. It's normal that they adopt this first. But then it's difficult to learn monoportal. I think if you learn monoportal, you will have both, and then you have the whole arsenal for your patients.
Okay, thank you. We got more questions from the chat. Is there any limitation in patients with facet hypertrophy for the interlaminar approach?
No.
No. So
no. I had a very difficult case a couple of weeks ago where there was no window at all. And also the first level, I struggled with anatomy and so on, and I said to me, no, that's stupid. The second level, I just went with the lateral X-ray at the level of the disc, and I did a hole and found the flavum, and from then go on. But there is no limit, I think, for that. The limit is rather the number of levels, because as it's more time consuming, you don't want to do 3 levels. That's clear. For me now, it's clear this is the limit. But still, I want to offer them that, because when I see those grandma who want to go the same evening home, I'm sure that's a very good thing.
Now, as you mentioned, the time, there's the question, how long does it take to do a unilateral approach, bilateral decompression of a stenosis by monoportal endoscopy? What's the average duration per second?
The average duration for me now is between 75 and 80 minutes. I have some cases where I was happy to go down to 60 minutes. I introduced that 3.5 years ago.
So the time advantage is more for the lumbar disc cases, where it's always said this is a 15-20 minute procedure, but for stenosis decompression, it usually takes longer than the
It takes longer, yeah.
Okay. Then we have an important question in the chat. Recommendations for European countries to include spinal endoscopy as part of the training for residents or fellows. And I'd like to extend this question a bit. I mean, my argument for some time against endoscopy was I need those standard disc herniations as training cases for my residents, as these are the first cases they do in residency apart from chronic subdurals. But do you think, is it necessary to have those open cases done before you adopt endoscopy? Or will we get to some point where a resident in neurosurgery will do his first lumbar disc herniation with a monoportal endoscopic technique?
Yes, that's a very good question. And I had several talks here in Sion with the general surgeons and with the urologist and with colleagues in other departments, general surgery, because I asked them, what do you do today? I mean, we are 30 years after the introduction of laparoscopy. What do you do today when you have a complicated case. And they said they called the old guy. And of course, this is not good, but they can't reverse it. It's not going to change. They do not do some cases open, so to train the youngster. They won't come back to open surgery. So probably I was always thinking, they have to learn first microscopic surgery and then go to, I'm not sure anymore. There is a big difference when I see, after 6 years of courses, I see orthopedic surgeon, neurosurgeon, newcomers, very experienced. And I see the newcomers, the beginners who have not a lot of microscopic surgery, they are very, very quick. And it's not only because they are young, maybe it's also because they don't have some microscopic reflexes. This is obvious by the use of the drill, for example. We have, with experienced guys, we have very often the guys who try to bring with the right hand and bend the drill to put it on the right spot, and it gets only the drill high and then it stops. This kind of reflex comes from microscopic experience, and it's, you know, it's integrated as motor reflex in your head, and it's very difficult to fight against it. And the youngster don't have that. So I think you can also learn from the very beginning endoscopic surgery. It's possible, and maybe it's going to come. We have the problem in neurosurgery that it's going much slower than the general surgeon adopted the gallbladder, but at the end we'll maybe come to the same. In Seoul by Kim Luke, I don't think the youngster know how to open.
We get to the same point as general surgery, where it's probably hard to find something.
And I was surprised they have no
open
strategy.
resection of a gallbladder.
Yeah, but they have no strategy for that. That's very interesting. And the complicated cases, they don't know how how will the future be.
Okay. Now, there's one final question in the chat. Whether you prefer inside-out technique or the opposite?
Or it's depending on the anatomical position of the pathology.
Yeah.
If it's mediolateral L4-5 discaniation, then we'll go through the foramen inside out. But if for all other pathology, extraforaminal or especially stenosis, stenotic foramen, then you will go safe and you will go outside in. For L5-S1 stenosis, we even take the O-arm. It's a lot maybe, but you go safe directly on the right spot and drill your SAP. And at the end, it's not such a long procedure. It's quite quick.
Okay. So I think we come to an end. Thanks again, Jean-Yves, for your very nice presentation and this very helpful discussion on practical things. I think that this gave very good insights in the opportunities of monoportal endoscopy and the very good tricks on how to overcome the learning curve. I think you can expect a lot of people who want to come to your course. Now, thanks again for this presentation. Thank you to all participants for your question and sharing the discussion and asking your questions. It was very good. So finally, I'd like to invite you to the next webinar of the EANS spine section, which will be on December 4. It will be a joint webinar with the WFNS spine section, and we'll have a view on thoracic disc herniations and look at thoracic disc herniations from different perspectives, again, including monoportal endoscopy, but also the open technique. So enjoy the rest of your evening, have a good time, and hopefully see you on December 4. Thanks a lot. Bye-bye.
Thank you. Bye-bye.